Hello, everyone, and welcome to the Down Syndrome Center of Western Pennsylvania podcast. As always, I am your host, Dr. Kishore Vellody, and it is awesome that we have today with us three guests who are here to talk about an incredibly important topic, and that is feeding issues, particularly in infants with Down syndrome. And depending on whether or not we get some information saying that people want more, we could one day perhaps record another podcast on older kids with Down syndrome and feeding. But today our focus will be on infants. And well, what I'd like to do, actually, if it's okay, just to have some brief introductions to you guys, if you guys would mind sharing who you are and what you do at Children's, and then we'll just get right into the podcast. Sheri, why don't we start with you?
Okay. My name is Sheri Rosen. I am a lead speech therapist. I have been working at Children's Hospital for over 20 years. And my primary focus right now is working with infants in the cardiac intensive care unit and the neonatal intensive care units.
Great. Jamie?
Hi, I'm Jamie Scheller. I'm an inpatient therapist as well for occupational therapy. I've been here at Children's Hospital for 9 years now, and I've been an occupational therapist now for 16 years. And I also work in our NICU and our cardiac ICU as well.
Wonderful. And Uzma?
All right. My name is Uzma Faisal. I'm a lactation consultant at the Children's Hospital for the past 1 year, but I've been practicing as a lactation consultant back in Georgia. And I've for the past 7-8 years. And currently at CHP, I'm covering the babies and the infants in the NICU, as well as throughout the whole hospital. So any families requiring help with not only breastfeeding, but also to maintain a good milk supply, I go around helping those families and babies.
Wonderful. Well, thank you all again for joining us on the podcast. And Uzma, I'd like to just start with you, actually. One of the things that we know within our center is that a lot of families get misinformation on breastfeeding, and particularly breastfeeding their infant with Down syndrome. Some families get told there's no way, it's impossible to breastfeed a baby with Down syndrome, just go to the bottle. And I kind of wanted to get your thoughts on what are some of those challenges that infants with Down syndrome can have with breastfeeding, and what are some ways that we can help support families to breastfeed their babies with Down syndrome?
All right. So so they get all kind of different information from a lot of people, but the good news is there are a lot of challenges. I will not say that it is an easy journey, but there are a lot of challenges. But the families, if they get the right kind of support, like not only the babies with the latching and everything, but the moms get good support from a good medical team, as well as lactation consultants, speech therapists, occupational therapists, we can help these families and the babies to breastfeed. And some of the challenges that we come across while we are trying to start or initiate breastfeeding in infants could be low muscle tone in their body, and also including the mouth, tongue, and the pharyngeal region, and their mouth, so it can make it very difficult. There could be hypotonia, low muscle tone in these areas. There could be uncoordinated sucking or weak sucking, or there could be difficulties in swallowing. But all of these do not have to be present in all babies. Some babies can have different problems, but we just need to find the right approach. Another problem that we come across is an inappropriate latch, because the mouth is small and the tongue is big. And it makes it difficult for these babies to make adequate vacuum. And there is a gap left at the corner of their mouth and their lips, so that they cannot make a good seal onto the breast nipple and the areolar region. But we can help them with different ways. But let's just go about with other problems that we can face. Some of them could be a non-rhythmic sucking, swallowing, and breathing pattern. And babies with hypotonia sometimes can also, arch back. They have arching of their body while they try to support their bodies if we try to, put them in a position for breastfeeding. And sometimes some of these babies can also have problems like gastrointestinal reflux disease because the muscle tone in the trunk, trachea, and esophagus is also decreased. And so they can have vomiting and painful breastfeeding. And apart from that, these babies get tired once they latch on, and they have decreased nursing time. And we can also think of ways to help them with that as well. There could also be aspiration of thin liquids while they are breastfeeding, and this could be problematic. And so, in my opinion, if we come across these challenges, not only the babies need help, but the moms need help too. They need to have a good support from the hospital team or the clinics wherever they are going for help, because they require to understand that they need patience and persistence, because these babies with our help can take a longer time to learn, but they will learn if they get the right kind of support and treatment. So our main focus on these babies with these special needs is to increase the tone in their face, mouth, and the tongue region, and for them to have improved oral motor skills, and they can be taught slowly and gradually. And if they get the right kind of support, they're able to latch on. So in my opinion, the first, like, just to console the moms, tell them that you can do it, but it might take you around 4 to 5 months for you and the baby to completely understand how to breastfeed the baby. And since they have, we can initiate breastfeeding as soon as the baby is in a stable condition, and the baby and the mom needs to be skin to skin as long as they can, and they can attempt to breastfeed 8 to 12 times a day in order for them to learn how to come to the breast and latch on. So for the muscle tone that is decreased in their body and so it's good to swaddle them up, like in a good position, so that their arms and legs are over their chest and crossed over. And there are certain kind of different positions that we can use. If latching is a problem, we can use some techniques like finger feeding in the initial few days. And finger feeding is a way when we place our finger into their mouth, and using a syringe when they start to suck, try to pour in a little bit of milk through that, like at least an ounce or so, before we put them at the breast. And a good position for them is a dancer's hold position, where they are sitting upright on the mom's lap, facing the mom, and the mom is providing them extra jaw support. So she is holding her breast from underneath, and her 3 fingers are going to be curled up on the backside, on one of the sides of the breast, and her thumb and index finger would be supporting the chin or the lower jaw of the baby, so that we can push it a little bit up, and the baby chin and jaw support helps. Along with that, they are also pushing the cheeks together so that the baby can form a better seal and latch on well. So these are a few things that we can try to help these moms understand how to breastfeed the babies.
Well, thanks so much. That's fantastic. And I think one of the things that I've always found amazing is even within our center, we'll sometimes have some parents who've had lots of children. In fact, I'm thinking of a couple of families where their 10th or 11th baby is the one who's born with Down syndrome, and all the babies before were breastfed. And moms will say, boy, this was a lot more challenging. But I agree with you. What we find is that with the right level of support from feeding team experts like you guys, the families are able to successfully breastfeed. So thank you so much, Uzma, for sharing all of that information with us. What I'd like to do is to kind of turn some families, for a variety of reasons, maybe from their own personal perspectives, or even as the baby gets older and the mom maybe has to go back to work, they need to start to work on bottle feeding. And I know that a lot of families have had challenges with even finding what's the right nipple, what's the right bottle type, or leakage coming out from the front of the mouth while the baby is bottle feeding. And so, Jamie, I was hoping you might be able to touch on some of those bottle feeding related issues for us.
Yeah, absolutely. And I think what's so exciting is that if we intervene early enough, we can capitalize on these babies and the fact that their skills are emerging. So if they have the right bottle to begin with, we can really work on those oral motor skills and increase their strength as they progress. So usually we like to see babies with Down syndrome use a more narrow bottle system. Now there's some bottles out there that have more of a wider base. Sometimes babies with Down syndrome have a more thrusting tongue and a wider latch. And what's challenging is that if we use a bottle system that supports that oral motor pattern, they might not have as much control over the liquid that's in their mouth. So usually, we often at Children's here, we use the Dr. Brown's bottle system, which is a more narrow bottle. Now that doesn't mean that it has to always be Dr. Brown's, but we're usually looking for something that teaches the baby to curl their tongue versus thrusting the tongue back and forward. And that way, when the fast-moving liquid gets into their mouth, they have a better control over what we call a bolus, or what's in their mouth. So then they can transfer it from the nipple down their throat efficiently. Now, sometimes with a narrow bottle system, initially, that baby might need a little bit of cheek or chin support to help close their latch or seal their latch, if that makes sense.
Yeah, it sounds like that's really similar to what Uzma was saying too, even with the breastfeeding, because of many of the times the lower tone in the mouth and all the structures within the mouth, that chin support can be so helpful. And I find that many times at the first visit that I have with the babies when they're, right after they're born, that families are amazed that those other fingers that aren't doing anything can actually be used to push that chin up. Is that kind of what you're talking about, helping to make that latch a little bit stronger there? Okay.
Yeah, and it's a skill that takes some time. Like, it's a lot of trial and error for parents. So sometimes when Sheri and I educate parents on, pushing on the bone of the chin, not the throat, but just the bone, and using one side of the cheek. And sometimes when the babies latch, you can hear that sound that they're losing some suction. So you kind of have to feel, where's that latch being lost? And that's kind of where you just put a little bit of pressure. And it's not by any means to force feed the baby or to get more volume, but it's just to support them in their muscle tone to make sure that they have a nice, strong latch.
And I think, for Jamie or Uzma, really, because I've heard this for both bottle feeding and breastfeeding, is that when that initial suck brings a lot of milk in, all of a sudden the baby's super hungry, hasn't fed for 3-4 hours, and they get that initial bolus of milk, that can be almost overwhelming, and they have some gagging or choking or something with the feed. Are there any things, we'll start with you, in terms of with breastfeeding, like with those initial sucks bringing in lots of milk, anything that you suggest to families to help to reduce that coughing, gagging that might happen at that time?
So we can have them in a sideways position. They are upright. Their head is a little higher as compared to the rest of their body. And if they are half sitting, like we discussed, the dancer's hold position, and they're getting the extra support for the chin. And I think that is going to take care of it, the proper positioning. And initially when they start to choke, we can, if being in the upright position and turned towards the side, can help them in that way to take care of it.
Perfect. And Jamie, what about with bottle feeding, things that you've used with families?
Well, one of the things that is a very easy fix is the position of the bottle. I think it's a misconception that the bottle needs to be at an angle with the nipple full so that the baby doesn't get air. And the first thing that we recommend is having a more parallel bottle with the nipple only half full. That way, the weight of the milk doesn't make the baby's mouth full before they're ready to suck. So really, the liquid only comes out when the baby is actively sucking. Then to piggyback off of Uzma, we do like the sideline position for bottle feeding as well. And you can do that on the lap or in the crib. But essentially the baby is totally on their side. And that way, if their mouth is full before they're ready to swallow, gravity will make it come out the side of the cheek versus in the back of their throat. So that really is the number 2 thing that we do to help reduce that gagging and gulping, because every time a baby gulps, they're swallowing air. And if a lot of these babies have reflux, that's just going to promote more reflux. So any kind of hard swallows or gulping, we really want to avoid. So positioning of the bottle and the baby is important, as well as the nipple flow rate. It's a very big misconception that we need to increase their flow rates so that they take more. But actually what we see is that if they're gulping or if they're drinking very fast, then they will stop because it doesn't feel right. So we usually will try to recommend something a little slower so that they can take their time and get into a good rhythm. What we want to see is sucking about 4 or 5 times and then taking a break, versus taking 1 or 2 sucks and then doing what we call catch-up breathing.
Okay.
Can I add one more thing to reduce the flow while breastfeeding? So
Yes.
if we find that there is a lot of gulping, then we can, try another position, which we called normally the Australian position, in which the mother is reclined back and the baby is on top of her, face down onto the chest. So gravity controls. So it's against gravity, and it also helps to control the flow while the baby is coming to the breast and has frequent gulping or coughing issues.
That's great. I didn't know that there even was this position, Australian position. That's wonderful. Thank you. That sounds great. Well, I guess, Sheri, let me turn to you at this point. When should a family get concerned? What's your opinion? Like, we've heard about, a little bit of gagging sometimes, and we can change some of the positioning and or nipple types and things like that. But when should a family really get concerned about how their infant is feeding?
So I think the most important thing is to try some of these techniques to decrease or eliminate the concern you're having. But if you are still seeing that by changing the position of the baby or the bottle or changing the nipple flow, that your baby is still struggling with gulping or with coughing or sputtering while they are taking their bottles, if they're sucking a couple of times and pulling away and just looking overwhelmed and uncomfortable with the feeding, those are all signs that he or she may not be managing the liquid as well as they need to. So especially if they're, if every once in a blue moon they have a little cough while they're feeding, I wouldn't worry about that so much. But if it's happening regularly, then it's definitely something that would be important to talk to your pediatrician or call into the Down Syndrome Center to discuss, to see if we need to do some more assessment with the baby.
Yeah, and part of our guidelines, actually, the American Academy of Pediatrics guidelines that came out for kids with Down syndrome, it really does focus on infant feeding patterns and says if there's a concern, then proceeding with a swallow study would be something that was indicated. And I was wondering if you might be able to touch on that. What exactly is a swallow study? Here in Pittsburgh, we have a tendency to call it something called a cookie swallow, which families often wonder, why am I feeding my infant cookies? You know, why are they calling it a cookie swallow? So I guess I wanted to kind of ask you more about what is that? What, if we're going to evaluate the swallow with a swallow study, what is it? How is it done? Things like that.
Sure. So the official name of a swallow study is either a modified barium swallow study or a video fluoroscopic swallow evaluation. So those are big, fancy, intimidating names, and a cookie study or a swallow study just is much easier and much less intimidating. If your child is older, they do actually get a cookie, but we are not going to give cookies to little teeny tiny babies.
That's a good thing.
So a swallow study is completed in radiology in conjunction with a radiologist. It's a moving picture X-ray of the actual swallow as it's happening. So we typically will start with the baby in a chair called a tumble form. It's similar to a car seat. And we can try to angle it similar to the position that you would be feeding your baby at home. To try to get the best assessment that we can. And then we would start typically with the bottles that you're using at home so that we can see what you were seeing. Throughout the process of the swallow study, depending on what we're finding, we may make some adjustments like changing the bottle or changing the flow rate of the nipple, trying to add in some of the techniques that Jamie and Uzma had mentioned earlier, to try to find the best fit for the baby. If we do see that even when we're trying to make all of these adjustments, that a little bit of the milk is going down the wrong pipe into the airway, then we may try to add a little bit of cereal into the liquid to see if that helps. And the reason that the thickening can sometimes help is that it helps to hold the liquid together into a more cohesive bolus or more cohesive mouthful. And it also makes it move more slowly so that the baby has more time to organize every swallow before the liquid's going over the back of his tongue.
So that's so what you're saying is, so when we talk about these swallow studies, it's really like it's a real time evaluation. Like as the baby is swallowing on X-ray, you can see exactly where that fluid, or if they're older, that solid is going. Is that what you're saying?
That is correct.
So I guess my question would be, so you're saying, the baby goes into that tumble form kind of seating, car seat almost environment. Who's doing the feeding during the swallow study? Is it the parent? Some parents have wondered, if I'm pregnant, is it okay for me to be? And I said, it's not you doing this feeding, but maybe you can explain that a little bit more.
Sure. So it's sometimes up to family's preference. If they feel that the baby feeds the best for them and they want to be the person that is feeding the infant, that is absolutely fine. At other times, they prefer to stand back and watch. And if we have the availability of a second speech therapist, which we often do, but not always, if we have the ability or the availability of a second speech therapist, we can ask that therapist to feed while the initial speech therapist is watching the swallow study. And that way we can kind of talk to the families as we're going so that they can see what we're seeing on the screen.
What do you guys do then if it's an exclusively breastfed infant and there's concerns for feeding? Are you able to do a swallow study on a breastfed infant?
So it's definitely trickier. The swallowing dynamics during breastfeeding and bottle feeding are different. So ideally, if we're doing a swallow study on a baby that's exclusively breastfed, they will have had at least some experience with the bottle. It's kind of unfair to the baby to have the first time they ever have a bottle in their mouth be during an assessment to make sure that they're swallowing it okay. So that's putting a lot of pressure on the infant. So ideally, we would have had the baby have some experience with bottles before the swallow study. So it is possible to do a swallow study on a baby that is exclusively breastfed. Unfortunately, as we can all imagine, we can't get the barium, which is the contrast that shows up on the X-ray, so that we can see what they are, how they are swallowing. We're not able to get that into a mother's breast, so we can't actually visualize actual breastfeeding. The liquid does have to come from a bottle for the swallow study.
Well, that's really helpful. Wow, this is fantastic. I really appreciate you guys coming on for this podcast. What are any thoughts, closing thoughts from anybody? Things that were like, oh, we should have mentioned that we didn't mention yet in this podcast?
So I think that, the families have a great resource in the Down Syndrome Center. We also have an outpatient feeding and swallowing center that specifically focuses on feeding in general, but that would be another good resource for them to have. In that clinic, there is typically a speech therapist and an occupational therapist. And then there's some other professionals that are available, including nutrition, a physician, practitioner, or a nurse. So during that appointment, they would watch the infant feed in its natural manner. This would not be a swallow study down with the radiation. This would just be watching him feed just like he would at home. And then they can make some adjustments or tweaks or recommendations based on that. So that's another resource for families as well.
It's definitely a resource we call upon quite a bit in our center. And so, yeah, we really appreciate all of the help that comes from that, from the feeding clinic as well. Well, if there's are there any other thoughts things that you guys wanted to bring up today on this podcast?
Yeah, I was just thinking, if a prenatal diagnosis is made for Down syndrome and the mom's ideal goal is to breastfeed, she should start seeking help from a lactation consultant or a team together with the the feeding team, and get information and resources right even before she gives birth to the baby, so that she is less overwhelmed at the time when she is actually going to start breastfeeding.
I think that's a wonderful idea. In fact, now that we're finding more and more often that families are finding out prenatally, at least a suspicion prenatally, I think it's so helpful to be prepared. I think that's wonderful. Thank you. Jamie, anything you wanted to add? Man, everybody's got a final parting thought. I don't want to put you on the spot here.
I just want to say, I think that it's important to know that every feeding experience is a learning experience for these babies. And so it's exciting to see them meet these milestones, and we love being a part of it. It's a huge blessing to us. So I would say that if you're seeing any red flags at home, or you have any questions, that it's best to seek out guidance from the very beginning, because it could just be a few little interventions or a few little recommendations, and we can make a huge impact. So we're here, and we're happy to help.
I agree. Well, thank you guys so much. I love that how easily your passion comes through on this podcast. So it's great to have you guys as a resource for any of our families. And I know that this podcast will be so helpful to so many families, really all over the world, that listen to this podcast. So thank you for that. For our listeners, we do appreciate you. We are closing in on almost 100,000 downloads of this podcast, which I think is so amazing. All over the world, 80 countries and counting have downloaded this podcast. So really great. So please do not hesitate at any time to please reach out to us at Down Syndrome Center at chp.edu with any podcast information you would like to have. We've had a lot of people be sending in things on COVID, of course, recently. We've been doing those podcasts, but anything else, any topics at all, we would love to cover on the podcast. But until next time, bye-bye.